Welcome to USMLE World, where we ask, answer, and explain USMLE questions. Today, we're diving into Step 2, Internal Medicine, focusing on endocrine, diabetes, and metabolism. Let's get started with question number 11. The following vignette applies to the next two questions in this episode. For the following case. The first question is, which of the following is most likely present in this patient? A. Adrenal cortical hyperplasia. B. Adrenal medullary hyperplasia. C. Leydig cell tumor. D. Pituitary adenoma. E. Seminoma. The case scenario is, a 4-year-old boy is brought to the clinic after his mother noticed he was developing pubic hair. The boy had a recent growth spurt and is now taller than his 5-year-old brother. The patient's preschool teacher recently mentioned he has body odor after he runs or plays. Height is at the 95th percentile for age, and weight is at the 80th percentile. Examination reveals sparse growth of long pigmented hair at the base of the penis and in both axillae. Testes are present bilaterally and appear normal. Laboratory assessment reveals high serum concentrations of 17-hydroxyprogesterone and testosterone. The question is, which of the following is most likely present in this patient? Your options are A. Adrenal cortical hyperplasia. B. Adrenal medullary hyperplasia. C. Leydig cell tumor. D. Pituitary adenoma. E. Seminoma. You have 15 seconds to type your answer in the comment box. Congratulations if your answer is A, which is adrenal cortical hyperplasia. This question is designed with the focus to assess your ability to apply foundational science concepts. Deficiency of 21-hydroxylase is the most common form of congenital adrenal hyperplasia and leads to impaired conversion of 17-hydroxyprogesterone to 11-deoxycortisol. Excess 17-hydroxyprogesterone is shunted away from cortisol synthesis toward androgen production. Adrenocorticotropic hormone increases due to the decline in cortisol levels and has a trophic effect on adrenal cortical cells, causing adrenal cortical hyperplasia. Depending on the residual enzyme activity, 21-hydroxylase deficiency can present as 3 distinct clinical syndromes of differing severity. This patient most likely has the classic, non-salt wasting, which simple virilizing, form of the disease. Because 21-hydroxylase is not completely absent, as in the most severe form, sufficient mineralocorticoids and glucocorticoids are maintained to avoid salt wasting such that patients have normal blood pressure and electrolytes. Due to adrenal androgen overproduction, girls with this variant are often identified at birth due to ambiguous genitalia. Boys appear normal at birth and typically present around age 2 to 4 with early virilization, such as body odor, pubic or axillary hair. Exposure to high levels of sex hormones also induces an early pubertal growth spurt that manifests as accelerated linear growth at a young age. In all forms of 21-hydroxylase deficiency, patients have increased 17-hydroxyprogesterone and androgen levels. Adrenal androgens, like dehydroepiandrosterone and androstenedione, undergo peripheral conversion to testosterone, which explains this patient's high testosterone level. If you choose any option other than A, you are wrong. Let's briefly discuss the other options. Choice B cannot be the answer because adrenal medullary hyperplasia is a precursor lesion for pheochromocytoma characterized by increased catecholamine production. Presenting signs include hypertension, tachycardia, and sweating, not virilization. Choice C cannot be the answer because Leydig cell tumors produce excess testosterone and can present with precocious puberty in young boys, like early testicular or phallic enlargement. A testicular mass is typically palpated on examination. Choice D cannot be the answer because production of excess LH and FSH by pituitary adenomas can lead to increased testosterone but not increased 17-hydroxyprogesterone levels. Pituitary adenomas producing excess adrenocorticotropic hormone can lead to excess adrenal androgen production. However, symptoms of excess cortisol production as in Cushing's syndrome like growth deceleration and weight gain would predominate. Choice E cannot be the answer because seminoma is a testicular tumor most commonly found in adolescents and adults. These tumors are derived from the seminiferous tubules and present with a testicular mass, not virilization or elevated testosterone. Your take-home message from this question is that deficiency of 21-hydroxylase causes adrenal cortical hyperplasia due to excess stimulation of the adrenal cortex by adrenocorticotropic hormone. The classic, non-salt wasting form presents in boys aged 2 to 4 with early virilization, accelerated linear growth, and elevated levels of 17-hydroxyprogesterone and androgens. Did you get the answer? If yes, let's proceed to the following question. The question is: after initial assessment, the appropriate interventions are initiated. Targeted suppression of which of the following hormones is the best next step to limit androgen overproduction? Your options are: A. Adrenocorticotropic hormone, B. Cortisol, C. Luteinizing hormone, D. Prolactin, E. Testosterone. You have 15 seconds to type your answer in the comment box. Congratulations if your answer is A, which is adrenocorticotropic hormone. This question is designed with the focus to assess your ability to apply pharmacotherapy. Patients with congenital adrenal hyperplasia due to 21-hydroxylase deficiency have impaired cortisol synthesis. Subsequent lack of feedback causes the hypothalamus to increase adrenocorticotropic hormone secretion by the anterior pituitary. This results in stimulation of the adrenal cortex and adrenal androgen overproduction, like dehydroepiandrosterone and androstenedione. Treatment of 21-hydroxylase deficiency involves low dose, which is physiologic doses of exogenous corticosteroids that suppress adrenocorticotropic hormone secretion via negative feedback mechanisms. Without excess adrenocorticotropic hormone stimulation, androgen production by the adrenal cortex decreases, which could precipitate an adrenal crisis, presenting as hypoglycemia or hypotension. If you choose any option other than A, you are wrong. Let's briefly discuss the other options. Choice B is wrong because deficiency of 21-hydroxylase impairs cortisol synthesis, further suppression of cortisol production. Choice C is wrong because luteinizing hormone stimulates the testes to produce testosterone. Decreasing LH levels would decrease testosterone production by the testes but would not affect excess adrenal androgen production in congenital adrenal hyperplasia. Choice D is wrong because hyperprolactinemia disrupts gonadotropic hormone secretion, which leads to decreased testosterone production and hypogonadism. Prolactin suppression would further elevate testosterone levels and would not be beneficial in this patient. Choice E is wrong because this patient's symptoms are the result of excessive production of adrenal androgens, like dehydroepiandrosterone and androstenedione, which can subsequently undergo peripheral conversion to testosterone. Blockade of testosterone alone would not be sufficient to prevent progression of this patient's symptoms, as the androgenic effects of these testosterone precursors would remain unopposed. Your take-home message from this question is that treatment of congenital adrenal hyperplasia due to 21-hydroxylase deficiency involves low doses of exogenous corticosteroids to suppress excess adrenocorticotropic hormone secretion, which reduces production of androgens by the adrenal cortex. Did you get the answer? Only click above to move on to the next question if you have the answer correct. If, however, your answer was wrong, you must watch this episode once more. Recall that comprehension is essential for advancement. Unlock the secret to acing your medical exams, especially the USMLE, with our top-notch resources. Ensure you and your friends are well prepared by hitting that like button, sharing this wealth of knowledge, and subscribing to our channel. Remember, your success is just a click away.